Duke University and NIH, and is currently the Frederick Haynes Professor of Medicine and Immunology at Duke University School of Medicine, and the director of the Duke Human Vaccine Institute, where his team of investigators are working on vaccines for emerging infections such as TB and HIV and flu. He has been the director of the NIAID-funded Center for HIV/AIDS Vaccine Immunology, known as Chewe, a consortium of 6 universities and academic medical centers that develop and test new vaccine strategies to overcome key immunologic roadblocks in HIV vaccine design. Furthermore, Dr. Haynes leads the Haynes Vaccine Discovery Consortium as a part of the collaboration for AIDS vaccine discovery funded by the Bill and Melinda Gates Foundation. Dr. Haynes is a member of the Institute of Medicine of the National Academy of Sciences, a fellow of the American Academy of Arts and Sciences, and a fellow of the Infectious Disease Society of America. I'm really pleased to have Barton Haynes here to present to us.
Thank you, Jay. I'm very grateful to be here. Over the next few minutes, I'd like to talk to you about a path forward for HIV-1 vaccine development. First question we should ask is, why try to develop an HIV vaccine? As you all know, the theme of this meeting is prevention of HIV, and that it is a major global priority. Treatment is prevention, microbicides, pre-exposure prophylaxis, voluntary male circumcision, and preventing mother-to-child transmission are all key components to the overall prevention portfolio. But should a preventive vaccine be developed, it will become the most powerful preventive tool and the cornerstone of an integrated preventive program. The next question is, how do vaccines work? Well, traditional viral vaccines like measles, mumps, and polio allow infections to occur but prevent symptoms and therefore prevent the disease. In contrast, a HIV vaccine must totally prevent infection. Once infection occurs, the virus inserts into the genome, the genetic material of the host it infects, and the immune system has difficulty controlling the virus. So a major mode of preventing HIV infection is going to be what we call neutralizing antibodies. What have the roadblocks been for HIV vaccine development over the past 25 years? Well, there have been many. 2 that I'd like to talk about today are the need to understand what types of antibodies can prevent transmission, and secondly, to discuss why we have been unable and to discuss our inability to induce broad neutralizing antibodies with current vaccines. What's happened in the last 2 years to invigorate the HIV vaccine field has been new clues have been found that we think are directing now HIV vaccine development. The first set of clues came from what's called an immune correlates of infection risk analysis found in the RV144 TI vaccine trial. Immune correlates are immune responses that predict whether a vaccinee who received a vaccine will become infected or not. Secondly, new broad neutralizing antibodies have been discovered that are very potent and neutralize many quasi-species around the world, and the role of the host in limiting broad neutralizing antibody induction has been discovered. Let's talk first about the RV144 TI vaccine trial. This is a Kaplan-Meier plot that shows, This is a Kaplan-Meier plot that shows in this line the placebo arm of the vaccine trial, and in this arm, those that received the vaccine and showed lower probability of HIV infection over time when receiving the vaccine with a 31.2% estimated vaccine efficacy. When this trial came out in 2009, a global consortium was organized to carry out an immune correlates analysis to begin to identify how this vaccine might have worked in order to point the way to learning how to make this vaccine better. This global consortium measured immune responses from 41 infected vaccinees, 205 uninfected vaccinees, 40 placebo recipients, and asked the question, what are the immunologic responses in vaccines that predict HIV-1 infection over a 3-year follow-up? This study was recently published in April in the New England Journal of Medicine at the reference you see there. Now, a bit of definition. What are immune correlates of risk? As I said, the correlate of risk of infection is an immune response that predicts whether vaccinees become HIV-1 infected. It's important to note in the interpretation of this work that it may be causally related to protection from infection, which is what we're interested in, or it may only be a surrogate marker for another factor. The study that was performed in and of itself cannot distinguish. Therefore, this type of analysis only raises hypotheses or clues for the field regarding immune responses, which immune responses might be protective. So the first hypothesis that was raised by this study was that antibodies of a type called IgG to a region of the envelope, this is the envelope of the virus with the virion down here, and the region is the V1, V2 loop region, and the hypothesis is that antibodies to V1, V2 can protect against HIV infection because the higher the level of antibodies to this region, the lower the incidence of transmission. And so the way the field is evaluating this correlate of risk is that the field is isolating V1, V2 antibodies from the vaccinees themselves as monoclonal antibodies. They're testing these antibodies for the ability to give them to rhesus macaques and then challenge those rhesus macaques with simian human immunodeficiency virus, retroviruses, and to see if they actually can protect. And then secondly, in the new efficacy trials going forward in South Africa and planned for Thailand, these antibodies will be tested again to see if in different trials, if they indeed are correlates of risk. Now, the second hypothesis that was found in the trial was a surprise. And this hypothesis is that monomeric IgA found in the plasma or the blood can block antibody binding to HIV-1 envelope on infected cells and prevent protective functions. Because what was found was the higher the level of plasma IgA to envelope, the higher the rate of transmission. Now, we do not believe that these antibodies caused enhancement, but rather that they mitigate the effect of otherwise protective antibodies. And so the way going forward that the field is pursuing to follow this clue is to isolate IgA envelope monoclonal antibodies from RV144 vaccinees, to test these antibodies for their ability to mitigate the protective effect of other antibodies in rhesus macaques challenged with SHIV retroviruses, and again, to test for IgA envelope antibodies as correlates of infection risk in new efficacy clinical trials, such as the new South African trial being planned. Now, what about broad neutralizing antibodies and the role of the host in limiting broad neutralizing antibody induction? So the first question is, why are we interested in broad neutralizing antibodies? Now again, broad neutralizing antibodies are antibodies that neutralize quasi-species around the world regardless of their type. Well, number one is the RV144 trial did not induce broad neutralizing antibodies. And so the hypothesis is that protection in that trial must have occurred via a non-broad neutralizing or a non-neutralizing mechanism, such as antibody killing of virus-infected cells. Broad neutralizing antibodies, in contrast, very potently protect rhesus macaques from challenge with simian human immunodeficiency viruses and are very potent in the test tube. However, the problem is, to date, no vaccine has yet induced broad neutralizing antibodies. So one of the things that has so energized the field is the discovery of a whole host of new broadly neutralizing antibodies that bind to vulnerable sites on the HIV envelope, the so-called envelope Achilles heels. And these sites are the CD4 binding site, the V1, V2 loop, the sugars, another glycan is a word for sugars that coat the envelope, and a piece of the envelope called the GP41 membrane proximal region. And these words and letters out here are all these new monoclonal antibodies that have been isolated by a variety of investigators. The point is, and the importance of these antibodies are that they all show greater breadth of neutralization. That is, they neutralize more isolates found around the world, and they're far more potent. You need less of these antibodies to neutralize than any antibodies previously found before the last 2 years. This is a model of the HIV envelope with the blue molecules, the sugar molecules covering the protein of the envelope in red, and shows these 4 Achilles heels, the membrane proximal region of GP41, some of the carbohydrates, the V1, V2 up here, and the CD4 binding site. The white box down here shows the group of investigators who have isolated many of these new antibodies. Now, this is what we want a vaccine to do and where we're working towards. These are crystal structures of these different new broad neutralizing antibodies here, shown in a model binding to this HIV envelope, and we want to induce with a vaccine a number of these broad neutralizing antibodies so that they will bind at once and prevent transmission. So to understand why we don't have a vaccine, I need to go over with you 3 definitions. And let's start down at the bottom first. Antibody self-reactivity is a trait of antibodies in which they bind multiple molecules, including self or our own molecules, in addition to infectious agents. And self-reactivity is also called autoreactivity. The term somatic mutations means a process in germinal centers, and germinal centers are where B cells live that make antibodies and where they grow to become strong antibodies. This is a process in germinal centers of acquisition of antibody mutations that lead to potent antibodies. And tolerance mechanisms are immune mechanisms that serve to protect the body and to remove or inactivate self-reactive antibodies. Here is a human antibody showing it's made up of 2 heavy chains and 2 light chains, and we want antibodies that bind very tightly to HIV to prevent infection. But interestingly, all of the new broad neutralizing antibodies isolated to date have one or more of the following unusual traits. First, they have long regions where antibodies bind to HIV, called antibody combining regions here. These are unduly long in many of the antibodies. The importance is that antibodies with long antibody combining regions are frequently eliminated by tolerance mechanisms. The second trait that broad neutralizing antibodies frequently have is they have excess accumulation of what's called these somatic mutations, these changes that occur that make them better antibodies. And the problem is that antibodies with too many of these somatic mutations are unusual because they are usually eliminated by tolerance deletion. And the third trait is that many of these are self-reactive with our own molecules in addition to reacting with the HIV envelope. And so antibodies with self-reactivity are usually frequently eliminated by tolerance deletion. And so in summary, the unusual traits of broad neutralizing antibodies are long antibody combining sites, extremely somatically mutated antibodies, and self-reactive, all of which predispose them to be susceptible to being prevented from being made by our bodies. So to study this, we've looked at initially these 2 antibodies called 2F5 and 4E10 that bind down here near the junction of the envelope and the viral membrane, and ask how are these regulated by a mammalian immune system? Are they indeed controlled by tolerance? And the way we've done this is to make what's called immunoglobulin humanized mice. And these are recombinant mice that only make one antibody, and in this case, they make one of these human broad neutralizing antibodies. And so we express this human broad neutralizing antibody and see if tolerance mechanisms delete or modify the antibody in mouse B cells. Now, for 20 years, this has been the gold standard by immunologists for determining how a mammalian immune system handles a particular antibody to determine, in this case, if the broad neutralizing unusual traits are sufficiently strong to induce tolerance mechanisms. In addition, once you have this animal model, it becomes an immunization model for trying to free up these antibodies with a vaccine. So if no immune tolerance interference with development of broad neutralizing antibodies is present, here is what we would see in this mouse. We would see the B cells making these antibodies start to develop early on, and then as they continue to develop, they would seed all of the parts of the immune system of the mouse and not be perturbed or deleted. But here is what we actually saw when we made both of these mice for both of these broad neutralizing antibodies. We saw the initial antibodies start to be made, and then as they tried to be further made, they became deleted, just as we were concerned about, with only a few B cells left around that were inactive and asleep. So in humans, what we're trying to do is to vaccinate such that there will be antibodies present, such that when transmission occurs with a transmitted founder virus, the antibodies will prevent the virus from infecting the person, and the person will be protected from HIV. What we're concerned about that has been happening with clinical trials in which we've not been able to induce broad neutralizing antibodies is that there's interference of induction of broad neutralizing antibodies by the host immune system, such that when antibodies try to be induced and the virus comes, it's the antibodies that go away, leaving only a few that are there but are asleep. So broad neutralizing antibodies are very unusual. They only occur in 15 to 20% of chronically infected subjects, and to date in no vaccinees. They all have one or more unusual traits that may be controlled by tolerance mechanisms. This mouse model of expressing only broad neutralizing antibodies shows that most of the cells are deleted, and for vaccinology, thank goodness, a few survive to be awakened by a vaccine. And so the goal is to awaken the remaining B cells in both mice and humans, and we're working hard on that. Now, what can we learn from patients in whom broad neutralizing antibodies do develop? This is a person, and they become infected with one virus that mutates into many different viruses over time, and such that by the time chronic infection occurs, there are many hundreds of thousands to millions of quasi-species in a chronically infected individual. Now, to see what happens to the antibodies, let's divide this person. It's the same person, and we see an initial transmitted founder virus starting and then mutating, and then we see in the same person on the right-hand side, antibodies start to develop, but they develop slowly. It takes about 6 weeks for a neutralizing antibody response to develop, and by that time, the host, our own bodies, have lost control of that particular virus. Perhaps the best way to understand what's going on in this situation is to use a metaphor that we're all familiar with, and that is of a nuclear arms race between two countries. One country makes a bomb, another country makes a bigger bomb. This first country makes an even bigger bomb. The second country retaliates with another bomb, bigger, and so on, until we're left with a cacophony of nuclear arms that are neither useful to either country and certainly deleterious to mankind. Now, what goes on in HIV is essentially the same. We start out with one virus in about 80% of people. This is work from the Chewe, that about 80% of people are infected with just one virus, one virion, one particle, and then that particle expands, and then there's an antibody made about 6 weeks later. But that antibody kills most of the transmitted founder virus, but then induces an escape virus that rapidly populates the person who's infected, and that induces another antibody, that induces another escape virus, and another antibody, and another escape virus, and so on, until we have a cacophony of virus quasi-species and antibodies that eventuate in 85% of people in a non or poor neutralizing antibody response. But fortunately, investigators have recently found that in 10 to 15% of people, the virus evolution goes in a different direction and drives the person's antibody responses where it can go, and to make one or more broadly neutralizing antibodies, here hopefully shown in gold. The question is, how do we recreate this scenario with a vaccine? Now, what the field has been doing for the past 3 or 4 years has been going to chronically infected subjects, patients, and screening them for whether they make broad neutralizing antibodies or not, and then isolating from these individuals the lineage of antibodies to exactly map how they get to the broad neutralizing antibodies. Now, in this setting, we have no information about how the virus evolves to drive these broad neutralizing antibodies. But we can still use this in our first strategy that I will talk about of using this to make an experimental vaccine. And the way we're doing this is called B-cell lineage vaccine design. And the key points to understanding how to do this are as follows. That number one, it's important to understand that an antibody a B-cell makes also serves as its surface receptor, recognizing those vaccines for that B-cell to grow and divide. And secondly, those vaccines that bind the strongest to the antibody of the B-cell are the best vaccines. And so the strategy that the field is using is to isolate antibodies, here antibody 1, 2, 3, and 4, that all come from the same naive B-cell, so they're in the same clonal lineage, and then to either use computational means or to actually isolate the antibodies. Here the unmutated ancestor is the original naive B-cell antibody that started off this lineage, and then its intermediates, and actually physically make these antibodies and use them over here as templates, and to select envelopes or envelope fragments that bind the best to each antibody step along the broad neutralizing clonal lineage. So the envelope that binds best to the unmutated ancestor, the naive B-cell receptor, will be our prime. Then the one that binds here will be our boost, and then a second boost, and if needed, a third boost. The goals of this B-lineage design is to drive broad neutralizing antibody lineages in the way we want them to go, to drive shorter lineages with fewer mutations that occur in chronically infected individuals that the immune system does not like, to drive lineages with either no self-reactivity or acceptable self-reactivity, so the immune system will allow these antibodies to be made, and therefore to give broad neutralizing lineages that are normally subdominant, that is, they don't progress very far, the ability to compete and to become dominant. Now, I've said that what would be most powerful would be to know what happened over here to the virus evolution that drove the right kind of antibody, the gold. What Chewe Immunogen Design has done, and several other groups have done as well, is to follow a number of individuals from the time of transmission with that single virus all the way through virus evolution to the time of development of broad neutralizing antibodies. And so we now have isolated a number of these pathways of virus evolution as well as the evolution of the antibody, because embedded in the evolution of the virus is the blueprint for vaccinologists to know the changes that occur and the sequential immunizations that occur to get to broad neutralizing antibodies. We're hopeful that we are not going to require hundreds or thousands of primes and boost, but rather 3 or 4 primes and boosts to drive a shortened version of this journey. So in conclusion, I can assure you that the HIV vaccine field is invigorated. We are working hard. We are collaborating with one another, and we're treating this problem as a global emergency. The RV144 immune correlates analysis has provided clues and hypotheses to test for finding immune correlates of protection, to figure out how that trial worked, and to ask the question, is there any way that we can make the results of that trial better so that a vaccine can be implemented? Secondly, the field is invigorated because of the discoveries of new broadly neutralizing antibodies and new insights into why broad neutralizing antibodies are not made. And these discoveries have provided hope that rational strategies can now be developed for broad neutralizing antibody elicitation by vaccines. I've been working on an HIV vaccine since 1985, and it's taken these 27 years for myself and the field to recognize that the complex biology of HIV, the escape mechanisms of the virus from broad neutralizing antibody induction, and the very unusual traits of the very antibodies that we want to induce when they are induced are necessitating completely new strategies of vaccine design that have not been used for vaccines to date. These new strategies for driving broad neutralizing lineages to become dominant are, number one, the strategy of using the broad neutralizing clonal lineages as templates called B-cell lineage immunogen design, and secondly, for mapping the virus and the antibody during this intense virus antibody arms race that occurs after HIV transmission. In doing so, we hope to recreate this scenario of the arms race with a vaccine and a strong adjuvant so that the vaccinee wins. Now, many of you may have heard in the last week or so 2 new awards, of which we were fortunate to receive one, the Chewe Center for HIV/AIDS Vaccine Immunology Immunogen Design. This is funded by NIAID and the Division of AIDS. This is our scientific leadership group of this grant, and our team leaders and our administrative team. A second group was awarded to Scripps Institute, led by Dennis Barton, who is the principal investigator of that group. And the Duke group are looking forward to working directly and closely with the Scripps group to bring a successful HIV vaccine to all of you for testing. The collaborators and the work that I've talked about today are listed on this slide. It's a wonderful group of collaborators, and I said the field has come together and is coming together even more in solidarity behind all of these efforts. And finally, I'd like to thank the funders of this, in particular the Bill and Melinda Gates Foundation and the National Institute of Allergy and Infectious Disease and the Division of AIDS. NIAID has funded the Center for HIV/AIDS Vaccine Immunology from 2005 to 2012, and now is funding both centers of HIV/AIDS Vaccine Immunology, Immunogen Discovery to go into 2019. Thank you very much.
Please welcome the Honourable Tanya Plibersek, MP, Australian Minister for Health.
Thank you. In our Australian tradition, I'd like to begin my remarks today by acknowledging the traditional owners of the land that we're meeting on today and pay my respect to their elders past and present. As a woman and as a mother, I'm particularly interested in the topic of our next speaker, turning the tide for children and youth. But as a feminist, I know that the empowerment of women, the economic, social and political empowerment of women, is the key to improving the health of women and their children. I have great pleasure in introducing Dr. Chewe Lau, who will be making the next presentation, Turning the Tide for Children and Youth. Dr. Lau is a paediatrician and tropical child health specialist from Zambia, currently working as Senior Program Advisor for HIV and Health with the United Nations Children's Fund, UNICEF, in New York. Dr. Lau has over 15 years' experience in HIV, AIDS and child health and holds postgraduate training in paediatrics from the Zambia School of Medicine and a Master's and PhD in tropical child health and epidemiology from the University of Liverpool in the UK. Dr. Lau is a global technical leader for scaling up countrywide HIV/AIDS programs with a focus on prevention of mother-to-child transmission, paediatric care and treatment, prevention of HIV in adolescents, and protection of affected children. Please join me in welcoming her to the session.
Thank you. I'd like to first of all thank the organizers of this meeting for inviting me to give this very important talk to this very important audience 12 years after I made the same plenary in Durban at the Durban Conference, International Conference. I must say up front that it's very exciting for us that work in the area of pediatric AIDS. What we've gone through, the trajectory that we've gone through since 2000, starting with the scientific breakthroughs, the commitment that we now have with governments scaling up these interventions, and finally the technical support and the financial support that we continue to have from the donor community. In the next 25 minutes, I will focus my discussion on elimination of mother-to-child transmission. Why is it that we have the confidence that we can eliminate mother-to-child transmission and keep mothers alive? The second part of my conversation will be around early infant diagnosis, the importance of that, and the importance of treatment of HIV-infected children. And finally, I want to talk about the second decade of life, adolescent prevention and treatment as a core mandate to what we have to do to turn the tide on children. And I'll end my conversation with a call to action. Some key concepts that have been driving the science behind mother-to-child transmission. I just want to say that transmission of HIV can occur during pregnancy, labor and delivery, and postpartum during breastfeeding. This is very, very important because we now know that if we are going to intervene, we have to intervene at all those time points. And that not all infants born to HIV-infected children will acquire HIV infection. And we know that the estimate in breastfeeding populations is around 25 to 45% without intervention. And the distribution of that risk is 10 to 25% during pregnancy, 35 to 40% during labor and delivery, 35 to 40% during breastfeeding. And that we've known as far back as 1994 that delivery of zidovudine as a prophylaxis to mothers to reduce viral load as a pre and post exposure prophylaxis to babies can actually reduce transmission risk in children by as much as 67%. And we know that translation of these results in the US, starting in 1994, was able to achieve a decline of 81% in new infections in children by 2000. And I just want to emphasize that this took 6 years, but it's taken us a long time to come to this point in low and middle income countries. But I want to emphasize that the time has changed, and just to refocus our attention that at the high-level forum in New York last year, a global plan to eliminate mother-to-child transmission and also keep mothers alive was launched. And I just want to mention that there were 2 high-level targets. One of the targets was to reduce new infections in children by 90% from the 430,000 baseline in 2009 to 43,000 in 2015. And what I've highlighted here is where we are. In 2010, we had 390,000 new infections in children, and in 2011, we had 330,000 new infections. And what I have in the pie chart is what countries are contributing, looking at the 2010 new infections, how much a country is contributing to that. I just want to highlight that 29% of the new infections are in Nigeria, 7% are in DRC, and 7% are in Malawi, and you can see the rest of the pie chart there. The second high-level target was actually to reduce HIV-related maternal mortality by 50% by 2015. We don't have data for this statistic for 2009, but what I've tried to do here is to look back. In 2005, there were 42,000 HIV-related maternal mortality, and what we're talking about is to reduce that to 21,000, and the statistic for 2010 was 330,000, and the contribution in the 22 high-burden countries that we're focusing on, Nigeria, again, makes up 20% of that HIV-related maternal mortality. So what gives us the confidence that we can eliminate mother-to-child transmission and we can reduce HIV-related mortality? This is not at all inclusive, but I've just highlighted some of the studies that have driven the agenda to give us the confidence that we can eliminate mother-to-child transmission of HIV. And I want to highlight the fact that after the PACTG 076, starting with the Thai study, the Petra study, the Uganda HIVNet 012, what we're trying to do at that point is to say, how can we make it simpler but effective for low resource settings with weak delivery systems? And what became very clear is that we had a huge issue with breastfeeding, and that unless we did something about protecting breastfeeding, because we know a lot of children in developing countries die from diarrhea-related mortality, pneumonia-related mortality, malnutrition, and that we could not do away with breastfeeding. Although the early guidance of WHO was that we needed to protect breastfeeding based on the Kustudi study in South Africa that looked at exclusive breastfeeding versus non-exclusive breastfeeding and demonstrated that exclusive breastfeeding was protective. Demonstrating that in the real world was very, very difficult. So just to mention that the future studies then looked at this, and we now have a situation where we know that giving triple therapy to pregnant women through breastfeeding or giving single-dose nevirapine through breastfeeding is actually protective. Now, although these studies are not comparative at all, we have the confidence that if we implement these results effectively, we can come to a point where we can reduce mother-to-child transmission in HIV-infected mothers to less than 5%. So how have we done in translating these results? I just want to highlight a number of key points. As soon as the Thai study was actually announced, the UN family actually came together and actually initiated pilot studies in 11 countries to actually look at feasibilities of implementing these interventions in these very weak systems. There was a call to action by Elizabeth Glaser Pediatric AIDS Foundation. There was the MTCT Plus initiative by the ICAP, Columbia University, and many other people, including the formation of the interagency task team for PMTCT by the UN agency that was then expanded to the other key actors in this field to oversee and to provide the technical support that was needed to actually implement these programs. And today we can actually say 57% in 2011 of women actually were able to access antiretroviral therapy, both for PMTCT and treatment of their own health. This is up from 48% that we reported last year for 2010. And I want to highlight the high coverage that we are seeing in Eastern and Southern Africa, 72%, in the Caribbean, 79%, in Eastern Europe and Central Asia, 79%. But the job is not done. We need to do better in Western Africa, for instance, where we only have 27% of women accessing. South Asia, we have issues there that we need to equally address. Now, when we look at this, we're making progress, as I've mentioned, but what does the trajectory look like in terms of the global target of reducing new HIV infections by 90%? UNICEF, the Business Leaders Council, and Clinton Health Access Initiative have actually released a document in this conference that is called the Business Case for B+, or Treating All HIV-Infected Women. And in that business case, we've actually modeled where we are now and where we're going, and if we continue business as usual, where we're gonna be. I just want to highlight that looking at the 2011 data, we estimate that the reduction from the 2010 baseline is 10.8%. Now, that's not enough. We know from the global plan that we have the indicator that we should have reduced this by 25% if we have to keep the trajectory to elimination or reduction by 90%. So what do we need to do differently? Where do we need to put our investment? This is a schema that talks to the four-pronged strategy of the UN that was coined in 2001. And looking at, and those tabs really are just, we need to close new infections in women. We need to make sure we reduce unmet need for family planning in HIV-positive women and women overall. And we also need to identify those women that are already infected, give them drugs, antiretroviral drugs, 90% of them, and reduce HIV transmission to less than 5%. And more importantly, we need to make sure that we provide ART to 90% of pregnant women in need of ART for their own health. And I'll come back to this point. I just want to applaud that one of the things we need to do is to make sure that as we provide these interventions to women, we ensure that we're using the most efficient delivery system, but also the most efficacious interventions that we know. And I just want to applaud WHO that in the event of what has been happening, I told you about the science and how much science we have, but WHO has been at the forefront to make sure that as evidence has evolved, they have translated that into guidance that then we've taken to the field to implement and make sure that women have access to it. What I highlight here is the 2010 and the 2012 update, and I just want to highlight a few things. I talked about the schema and the transmission risk across pregnancy, labor, and delivery, as well as breastfeeding, but I just want to say that in the 2010 guidelines, WHO recognized that we needed to raise the bar of treatment in women to 350. And I just want to make that point because that's the distinction between what was released in 2006 and what the 2010 guidelines actually talked about. The other thing that the 2010 guidelines talked about, based on the Lauman study in Thailand, was that we needed to start treatment earlier than what we had been doing, which was 36 weeks in the Thai study and other studies that followed. The second part of this is that apart from treating women that were in need of treatment, based on the scientific evidence that we had, two options for prevention were actually proposed by WHO. One was based on an AZT backbone monotherapy, switching to lamivudine and AZT during delivery, and then some drug to baby and mother post-delivery. The second option, prevention option, was actually triple therapy to mother from 14 weeks through delivery and postpartum during breastfeeding. What has happened with the update in 2012 and looking at the operationalization of the 2010 guidelines and the challenges that we have is that WHO now has come up with a third option, which is option B+, which is about giving triple therapy to all pregnant women regardless of CD4 for life. Now, this is all very welcome news, and I am one person that's very excited about this new development, knowing how challenging it is in some of these settings in delivering the 2010 guidelines, very complex agenda, and I'm sure people in this room can agree with me. But how have countries actually adopted these guidelines? And what I have here is a chart that talks about different countries and the different options, focusing on the prevention option. Remember that the women that need treatment should have it. So this is focusing on the prevention option. You find that for most of the high burden countries that have the weakest systems, the option that they've selected is option A, and then you see in the middle the option B countries, and then Malawi was the only country that chose option B+, and I'll come back to Malawi. The issue with this is that many of the countries, and we've done a recent evaluation with the Global Fund and UNICEF, looking at this in terms of the decision-making points in each of the countries, many of the countries were actually basing a lot of their decision on cost. And I just want to highlight this report by Audi that was presented in Vienna in 2010, where they actually analyzed, building on scenarios for 26 guidelines, scenario A, which is the option A, and scenario B, which is option B. And I just want to highlight that when you look at the options through this model data in 15 focus countries, there seems to be very little difference between option A and option B. Now remember, this is model data, and 26 guidelines seems to be less effective. But when you move down to cost, that's where you see the biggest difference. 288 million estimated per year versus 171 million estimated per year for option A. Now, a lot of the arguments within this also has to do with what regimens countries are choosing. If you look at the 2010 guidelines, there were variable options that countries could choose from. And the fear of using ephedrins in pregnancy meant that most of the countries were choosing a PI-based regimen for prophylaxis for pregnant women, and hence the higher cost in the estimate. But operationally, it's not that simple. And I just want to show the schema that is in our business case for option B+, that looks at the cascade of CD4. How is CD4 performing in our settings to be confident that we'll be able to operationalize the 2010 guidelines? And you can see that cascade from the time the blood is drawn, the CD4 test result is received, whether the woman even initiates treatment, and the fact that a lot of these women will not even come back to deliver. This is the bottom line. And so the idea that we are focusing on prevention, and in a lot of these countries, the default when CD4 is not available is prevention, the prophylaxis. But I just want to highlight here from work by Kuhn and colleagues at Columbia University in Zambia, looking at a cohort of 1,025 pregnant women in Zambia, and looking at if you did a CD4 and you did screening, clinical screening, what proportion of these women will actually need treatment? And the statistic there is 68.1%. Now, we have a range of about 40 to 50%, but this is what was found in the study in Zambia. And I just want to highlight that when you look at the 21.7% infections that happened, 87.5% of these infections actually happened in women that were eligible for treatment using the cutoff of 350. And when you look at mortality 2 years on, of the women that died, 82% of them were also treatment eligible. So the idea that our programs are focused on prevention has to change. We need to look at PMTCT as a component of ART. And I just want to continue this argument and looking at the study by Hargrove and colleagues in Zimbabwe, and looking at what happens to these women even at higher CD4. And you see in this slide that actually for HIV positive women, mortality is still higher when you have CD4 close to 1,000, 3.9 times. When CD4 is close to 2,000, 2.5 times. So again, the argument that we have a prevention program for mother-to-child transmission, I think has to go. We need to find ways of making sure that these women actually access treatment early. And I could talk about Mary Glenn Fowler's study that was presented at CROI last year, looking at women who have higher CD4. If they have CD4 between 350 and 500, how many of them in the next pregnancy will actually have lower CD4 that warrants initiation of treatment? And the study was very clear that these women in that category, 1/3 of them will need treatment in the next pregnancy. So the work by Belzy and Chewe, and I'm sure Lorraine is in the audience, looking at all this and saying, what is then happening with orphaning in children? And again, we find that because we are implementing programs that are focused on prevention, orphaning will continue to increase if we don't actually provide treatment for women. And this is true even for countries like Namibia and Swaziland that have very good PMTCT programs in terms of how many women are accessing the intervention. So I come back to Malawi, and this is the bottom line for me. Malawi, a very small country with a small population, very little capacity, minimal lab capacity in that country, looked at the 2010 guidelines and said for them it didn't make sense because they would never have universal CD4 screening for pregnant women. They also thought through the rates of breastfeeding in women and how long the women were going to breastfeed, the whole idea that fertility was very high in Malawi and that you would have to stop and start in Malawi, even in the situation that we're in. And they were not willing to stop and start, and they decided that for them, what they needed, even given the new evidence of the potential for reduced transmission in sexual partners, for them what was appropriate was one standard for their ART program and their PMTCT program. So what they decided to opt for is treatment for all pregnant women, which now WHO has embraced. Now, moving on, in this conference, Malawi has presented some of their results. For us, it's very, very exciting to note that in less than 1 year of implementation, Malawi started implementing in 2011. If you look at Q2 results and look at the yellow bar, which is pregnant women, and you look at Q4 results, which has yellow and pink, and the pink are breastfeeding women, you start to see the trajectory of where the Malawi program is going. In Q2 of 2011, only 1,200 women actually accessed treatment in Malawi. And by Q4, 15,000 pregnant women and breastfeeding women were able to access treatment using this simplified approach, and I want to quote, simplified, that could be delivered in the lowest services of care in Malawi in maternal child health services. I just want to also show you a different slide on Malawi, looking at the global targets in the global plan, which is basically how many women in Malawi are actually accessing ARVs, which is the first slide there. And you see that in 2009, only 24% of women in Malawi were accessing ARVs for mother-to-child transmission when you exclude nevirapine. And by 2011, they had 53%. Now, because Malawi is offering a treatment program for all pregnant women, you see in the next slide that although they had only 12% of women accessing treatment in 2009, this increased to 51% in 2011. I just want to highlight how making it simple can actually achieve so much, and I think we have to applaud Malawi for being so bold to actually provide this. Now, I talked about the business case on option B+ that we've released in this conference. Within that case, we've also modeled what the potential benefits of this is. And I won't talk about reducing infant infections because that's obvious, but look at what happens in the yellow to reduction in HIV-related maternal mortality, and in the yellow below to reduce transmission in HIV sexual partners. I think the argument is clear that if we have to optimize what we are doing, we have to transform our PMTCT programs into ART programs. Now, this is not going to be simple, and I just want to highlight one point which I've already made with Malawi, is that it's not going to happen in the centralized hospitals or the regional hospitals. It's going to have to happen in MCH clinics at the primary level, in the primary level facilities, and that we really need to foster, as a global community, integrated MCH services that adequately integrates TB, ART, and PMTCT interventions that reaches out also to the family into one service, and that this is the only way we're going to adequately link these services to communities, allowing women living with HIV to support the mothers and to make sure that they're adhering to their clinic visits and also to the drug intervention. But having said that, I did talk about the four-pronged strategy and the elements within that. We must not forget the fact that new infections are happening as we sit here. And I would like to applaud South Africa for achieving a transmission rate of less than 3.5%, but it is in a country where the prevalence of HIV in pregnant women and adolescents is extremely high. And we know that as new infections happen, these women are more efficient in transmitting the virus to their baby. And we also know that every infection that happens is between somebody that is infected and somebody that is not infected. And I want to just raise the point that in a study in Rwanda and Zambia, the fact that in married couples, when one partner is positive, over 40% of their partners may be negative, also means that we have to transform these programs to target not only women, but also men as well. And I want to applaud WHO for issuing the guidance on couple testing, and it's up to us now to look at this and see how we can operationalize this in our programs. The second thing that I want to talk about is also related to the fact that we have evidence. We have evidence for primary prevention. We have evidence, HPTN 052, targeting discordant couples. We have evidence around circumcision, and we just need to apply this evidence. And I want to also say that this evidence is not just applicable to high-burden countries where there's heterosexual transmission. Julio in Colombia has also proven beyond reasonable doubt that this works in IDUs and also has impact on mother-to-child transmission. And I think we need to make sure that we do that. I want to just spend a few moments now focusing on family planning. And just to say that the meeting that just happened in London, where the US government, the UK government, Bill and Melinda Gates, and UNFPA committed to actually changing the paradigm of the current stagnation in family planning. Over the last decade, we have not made any inroad in family planning. And this is true both for HIV-positive women and HIV-negative women, although in one study in Zambia, there was some indication that unmet need for family planning is much lower in pregnant women, but in most countries, this is not the case. So what about children? The statistic that only 28% of children are accessing treatment is unacceptable, because we know that without intervention, 50% of these children will die by the second birthday. We also know that from the Chewe study, that early initiation of treatment in these children can reduce mortality by as much as 76%. But we're failing to reach these children. This is a slide that I got from Elaine Abrams at Columbia, ICA program, looking at the trajectory between 2005 and 2010. And if you look in the yellow, less than 20% of children are identified before their first birthday to initiate treatment. And we found the same findings in our 5-country review looking at this. And part of the problem is that even though we thought dry blood spot would be the game changer for early infant diagnosis and linking facilities to laboratories and children to testing, you see here that looking at the children that we tested and following them through 1 year on, 76% of these children, we don't know what happened to them. They would have died or lost to follow-up. So we need to do a better job at identifying these children. People have tried out SMS technologies and other technologies to try and improve on this. I just want to applaud Unitaid here loudly for actually reporting yesterday or 2 days ago that they are releasing $140 million to look at the viral load and EID pipeline in terms of point-of-care technologies, including CD4. But this is not good enough. The first EID, the EID point-of-care technology, if you look at this schema, is only going to be available to us in between 2014 and 2015. And we still need to see how best we can improve on what we are doing with dry blood spots. And I just want to end on children with a slide that looks at the fact that for children, we still need simplified dosing platforms. And research needs to continue to look at this, and Gibb and colleagues through the CHAPAS trial have been looking at this. They were the first to come up with a fixed dose combination, Triomune. They're now looking at liquid lopinavir, looking at how it performs versus tablets, how it performs versus sprinkles. We need more of this research moving forward. So finally, what about adolescents? 2.2 million of children between 10 to 18 are HIV infected. And we know that a lot of these infections in adolescents are actually happening in adolescents. So the key question for me, without having done any analysis, we're very busy with the global plan to reduce mother-to-child transmission. We're very busy with trying to treat children that are infected. But if we don't protect the second decade of life, all that investment will yield nothing. And I think my call to all of you is that we really need to focus on this. We really need some championship around the evidence that we have and how we can actually make it happen. A lot of countries are very comfortable doing the things in the yellow in terms of their response. But what I would like to challenge you, and that this is not just me, but UNICEF, is that we need to be in the purple box. We need to make sure that we're testing young people. We need to make sure that we're treating those that are infected. We're identifying them and treating them. We need to be comfortable with young MSMs. We need to be comfortable with young female sex workers. We need to be comfortable with young IDUs and make sure that they have access to services to actually protect them from getting infected. And finally, the circumcision agenda for me is something we have to do and we must do. So I would like to end with a call to action. And my first statement is that to move forward on this agenda, we need to simplify our programmatic approaches to allow effective integration of both PMTCT, ART, in maternal child health services at the lowest levels of care to optimize treatment access, adherence, and retention. Second, we need to introduce innovative approaches to expand provider-initiated testing to adolescents, pregnant women, and their partners. And fourth, we need to make sure we change the trajectory of treatment access in children and make sure that we operationalize what needs to be done at the lowest levels of care within child survival programs. And fourth, we need to collaborate with community groups, including women living with HIV, to enhance support to women and their families to maintain good adherence, retention into care. And finally, I just want to again echo that we have to and we must focus on adolescents and make sure that adolescents have access to high impact interventions. Thank you.
Please welcome Dr. Mabel Bianco, a leading advocate for women's rights in Argentina and worldwide for more than 4 decades. Dr. Bianco is the founder and director of the Foundation and Research on Women based in Buenos Aires. She's the coordinator of the International AIDS Caucus.
Good morning. I want to start saying that I'm very happy and very honored to co-chair this session, not only due to the issue that they are the women issues and so important for us, but also because it's a plenary session in which we have no gender balance. So I'm very happy. It's the first time I saw one of these plenary sessions with more women. So, we have been working so long to have this result that I'm very honored. Thank you for all the organizers. I'm invited, and this is another great honor, to present Linda Scruggs. Linda Scruggs is really a leader of the women living with HIV and of all women here. It's difficult and a great challenge for me to summarize her CV, but I want to only let you know some few issues. Then you are going to know her and you can better know how she is and how good she is. She started in 1992 working on women's issues related to HIV as an educator, as an advocate, in Johns Hopkins University, and then moved to Ed Services in Maryland, in Baltimore. But I think the most important issue is how she really, all these 20 years, she works to empower women living with HIV and the families, but all the women, in order to be able to participate in partnership as community members. And this is something that really is great because she continued doing that, and also because she became a leader and recognized. She has many recognitions, but I only want to mention that 2 years ago she received an honorable mention from President Obama because of her work. But also she's a mother of 3, and she's minister in the church in her city, and she's coming here to talk, but also to present the new voices and the faces of the women living with HIV worldwide. So I'm not going to continue saying things because I want to listen, and all of you invite to listen Linda. Thank you.
Good morning, everyone. First, just allow me a moment to be in the moment of awe, to give honor to my God for this extraordinary moment, to be here to join you as we do something very dear to my heart, is to speak about the impact of HIV on women. I want to thank the International AIDS Society, all of my affiliates, my professional affiliates, my colleagues, the conference planners, the women who wrote letters and found me worthy to come to this platform this morning. I would like to give a special thank you to the women of the Women's Networking Zone, the positive women of the U.S. Positive Women's Network, from women from around the world who've given their faces that you will see on the screens to be with me, to be my co-presenters this morning. I want to give honor to my loving family. Many of you who've heard me talk over the years have heard me talk and speak of the greatest woman that I know in the world. She's my mother. She's here with me this morning. I give honor to her. I give honor to my sister from traveling from Anguilla, the British West Indies, did not find it robbery to stand here with her youngest sister this morning. I give honor to my son, my youngest son, Isaiah. It is he that I was 13 weeks pregnant on a cold November day while visiting a perinatal clinic in Johns Hopkins in Baltimore, Maryland, that I had to face a critical decision at 4:15 in the afternoon at receiving an HIV diagnosis, and I was given the choice to terminate the pregnancy and live 5 years, or have this child and possibly live 3. Well, I'm glad that day the doctor was wrong. I gave birth to the most handsomest young man in the world who just turned 21 and who's HIV free. Lastly but not least, to my general. I was in South Africa in 2000 in Durban, and I met an elder, and he told me that God was preparing a general for me. As a single woman not looking for a date, but I thank God that he sent me Nathaniel Scruggs, my loving, my general in my life. I want to speak to you just for a moment about women's needs, and I'm going to get to the point. I'm a storyteller, and when I received the invite to be here, hundreds of emails came to me when people found out I would be on this platform. So there's a lot of expectation. But the people who advocated for me to be here asked me not to talk from the credentials that I received at Lincoln University, the work that I've done as a consultant or as a collaborator or as a capacity building assistant. They asked me to speak from that experience that November day when my life changed, when HIV became not just someone else's issue, not someone else's problem. They wanted me to speak to the woman who still, 22 years later, whether you see it or not, HIV still runs through my veins. In 2006, at the international conference, one of my fellow sisters, Louise Binder from Canada, told us the reality of our lives as women is that gender equality is the economical, social, and educational and political errors directly impacted by our ability to protect ourselves as women. Louise also said in her plenary speech in 2006 is that HIV is a result, not the cause of these equalities. So what? The solution for women is not mainstreaming us, we are different. Not ghettoizing us, we're not all underserved, but it's an integration of a complex, comprehensive system that will have to be addressed to surely meet all of our needs. In Vienna just 2 years ago, my sister Waida Shabazz-Ilah set the stage for us being here in the U.S. today. Waida expressed her concerns around a collective issue of women about a systematic human rights and the violation of women and girls. The HIV travels, she said, well-worn path of gender equality. Globally, women and girls are forced for sterilization, criminalization of sex workers, and HIV transmission. These excerpts from these two women are very powerful to me, but they're just simply talking about women's human rights. I'm not going to ask you for anything. I think women have been, for the last 2 decades, if not more, have been asking not only the international conference, but the international platform that's worked on behalf of people with HIV. We've been asking to count us in. We've been asking to be a part of. But today I stand to you to give you some directions. We've decided to stop asking, and maybe you just need the recipe. To turn the tide on behalf of women, we must accurately count all women and all of our diversity into research. We cannot no longer satisfy for being a count of less than 10 or maybe even 10% in anything that you want to do, that you want us to be a part of. We must turn the tide, and you must meaningfully involve women at all levels of authority, within the government, within our local communities, within organizational. As we are expanding services and opportunities for women, we need to be able to put women in a position of leadership and authority within the titles that they serve. We're not asking just for male-ran organizations that will tolerate a women's program. We want women to have the tools to follow the research for us, by us, with us. We have come to a place we're not asking you, we're telling you there is a time to address the inequality and imbalance against women in HIV globally. It's not enough to create task force and write papers. We need to be part of the solution. We need the support and the resources that follow the issues to give us the power to heal our sisters, to change our land. We are the mothers of the earth. It's time to turn the tide at our national strategies, including the U.S. strategy on AIDS that President Obama signed in 2 years ago. It's not enough to vaguely include us into the work. We're more than 50% of the epidemic, nothing taken away from the gentleman on this plenary, but I would hope in Australia we have a plenary all to ourselves, all about women, acknowledging we are in this fight. there is complexities that go along with what's happening in our lives. Now that's what the directive is. But let me also share with you part of probably what got me to the stage today. It's not just that I sat in that clinic in November. I had an experience standing at a bus stop in Baltimore. And I want to apologize for the experience, because the experience was with my God. I don't think I ever had the opportunity to ask why me. My life had never been a cup of tea. I understood why me. I understood there was things in my life and my past that would get me there. I would tell you at the point of my diagnosis, as I was a full-grown woman, it was interesting because when I think back, just like any time you talk about something, you do something, you're challenged to do something. I was challenged to do this work. I didn't understand womanhood when I found myself pregnant at 25 years old. I didn't understand womanhood when I had to make the choice whether to abort this child and see what I had already seen on television or what I have known just from other women who were dealing with a child with HIV. I could have made the decision to have an abortion. An abortion would not have been the first one I had had. But I had an experience with God. I had an experience that taught me, made me really to look and to reflect about woman. After all, what is a woman who thinks she's ugly? What is a woman who feels she has no self-value? What is a woman who allowed not one but two men to rape her in silence? What is a woman who allowed her uncle to molest her and others and still be silent? What is a woman who feels she cannot read and write to a U.S. high school education? What is a woman who feels that she's been broken and voiceless? What is a woman who's afraid of understanding herself? What is a woman who spent a lifetime trying to be someone else other than her? I'll tell you, that cold November day, that woman was me. But it was through the support of this community that I was able to find a voice and a place that I could be just who I say I am. I am a woman. It was... I believe I just celebrated over 20 years of drug delivery. I've been monogamous, sleeping with one man. That's worth an applause. Trust me. Trust me. May not be your choice. It's okay. I'm a sexual being, and I chose one man. It has not always been my story. But it was a goal that I accomplished. I came here into this community thinking I was different. I'm not from the ghetto. I'm not from an underserved community. My parents both lived in a household. We had 2 incomes. I wore designer jeans and designer shoes. But somewhere along the way, I created a new path outside of what they were designing for me. I was lost. Trauma had entered my life very early. It created a Band-Aid, and I began to wear masks that were cover and cover. It is powerful for me to stand here and to be with you and to understand that it was when I was working at Johns Hopkins and I met a woman named Karen. Before Karen even entered the clinic, I was a women's health advocate. She was there to come to get some help from me. All the clinic staff warned me of her before she even could come in. They told me, watch out, don't turn your back. She's dangerous. Me being me, I'm a little county girl. I'm a suburbanite. And I'm in the inner hearts of Baltimore City. And Karen walked in, little teeny woman, and she had rough written all over her. And I had just a moment to swallow before I became alarmed at what I saw. And I remembered what I heard. But I thank God that I had an encounter and I understood what it meant to meet someone just where they were. At that moment, I invited her to go away because she came into my office and she began to drift off as the heroin began to set effect. She gave me an out to listen to the clinicians and the folks who warned me about her. I did what I did. I opened the door and I asked her to come back when she was able to talk to me. As she left, I felt real empowered. Why would I feel empowered? When she came for help and I offered her nothing. I went to the waiting room and there she was sitting, still nodding. And something said to me, just sit there and wait. She's worth the wait. When she woke up, I asked her to forgive me. I asked her, was she able to come and chat with me now? And after many choice words that I dare not say here, I took them all. She came into my office. And what was quite interesting, 4 years, 5 years later, working with Karen, many a relapse, her imprisonment, her homelessness. I learned more from her and those women in inner city Baltimore than I had learned in a lifetime. Incredible. I'm glad to tell you that Karen has now over 10 years drug-free. Then there's Miss Gray. We're gonna call her Miss Gray. I met Miss Gray when I moved back to DC in about 2005. I met Miss Gray at a private health care clinic here in the city. We're calling her Miss Gray, okay? Because there's a reason. Not everyone's walking around with a button that says, I'm HIV positive and I live in your community. Miss Gray was in the clinic. I didn't know her and she didn't know me, but she was crying. And me being me, folks who know me, I'm not nosy, God just wants me to know a lot. I gave her a Kleenex. And as I gave her the Kleenex, the conversation began. And she shared with me that she was a widow. She was from Michigan, and they moved to Northern Virginia so that, after all, they told their friends and their family Mr. Gray had lung cancer. And her new job would provide a safe place away from the eyes, insurance that would adequately give him care. Ms. Gray has stayed out of care for a long time. Mr. Gray died in 2000, and she was just entering care of an HIV diagnosis in 2005. Ms. Gray is a vice president of a national corporation. She has a private driver. Her means are met, but yet she's living in Northern Virginia. And like Karen and me, HIV is running through her veins. There are many stories between Karen. Oh, did I tell you? I introduced Ms. Gray to a lot of wonderful women. As a result of her getting education, being able to network with other women like her, she went back to her large corporation where there's over 15,000 employees, and she incorporated a women's health initiative that includes women in HIV, women in violence, using influence and power, whether we're in the shooting galleries going and look for our clients, or we're in corporations where we have power and authority, women do count. It was coming back from South Africa, Durban, that I went there thinking that I was going to become an international phenomenon. I went there thinking I'm going to meet people, I want to take these ideas, because I dream programs, I dream realities, I dream vision. I believe in a comprehensive agenda for women includes hope. It includes comfort. It includes nourishment. It includes allowing her to understand you can forgive yourself. What he did to you wasn't about you. What he told you love wasn't love. Some women feel guilty because they enjoyed the molestation. It wasn't molestation till I found out that it was wrong. How do we agree to disagree with the complexities that women bring to our communities? HIV in the US and many countries the treatment and the systems were not designed for us. It was designed for a gay male society. No one was thinking about us. We weren't at the rooms. Some of us were in the labs as assistants and researchers following someone else's lead. But I'll tell you, we're at the table. We're here and we're a force to be reckoned with. We're changing the game. In the words of Michelle Obama, a quote I found, and I wish I read the whole thing to make sure that it was in content, and I'm gonna find it because I don't want to be out of content. Michelle was giving a speech and she wasn't talking about HIV, but I think it is what we're talking about today. Michelle Obama said, we need a big change, not just a shifting of power among the insiders. And there's no more insiders than being inside of Washington, D.C. We need to change the game because the game is broken. We don't have another 30 years. We don't have another 30 years. We don't need another 30 years as women. We need you to do it now. We need you to go back into your communities. We need you to take a picture of what's happened here in DC this week. Go back into your communities and meaningfully look at your programs. What do you need to do to retool? There is no more money right now. But many of us have programs that some shifting is going to have to happen any old way. Resources are going to have to be moved around any old way. We want PEPFAR refunded. We want the Global Fund refunded. We want Ryan White reauthorized. But there's going to have to be some shifting. And in that shifting, we want an intentional shifting of women. We want an intentional thought. We want women at the table as you make decisions on how do you shift and include us. Women being retained and access to care, research around research, it's already been done. We connect with women. We understand the complexities of waking up in the morning, putting on the coffee pot, getting the kids ready for school, looking around the room to see, are you up yet? Are your shoes, is your tie, is your dress, whatever it is you have, are you taken care of before I can even begin to put on my pantyhose? Women understand the choices between work and utilizing sex workers and creating opportunities that, you know what, she don't have to get more, not use the condom. We need to create jobs for women with HIV. It's not enough. It should be unacceptable that in 2012 that programs are still providing meaningless stipends versus providing and directing women to the skills and training that they need to not only be part of the result, to be a living part of the economy in our local communities. I'm appalled when I still hear providers say, well, we only can give her that much because of her SSI. Bad provider. Bad Jew. We need skills. We need to direct women to the places where they can do and be productive citizens, productive financial earners within their own homes, within their own communities. I don't know nobody that's looking forward to going to ask the government for anything to have a means. We keep bringing them to meetings. We ask them to speak on our behalf. Let's give them the skills to be at the table. I don't have a timer up here, but I want to say one thing before I take my seat. There are a lot of women between Karen's story and Ms. Gray's story. There are a lot of women. I find myself in the middle somewhere. I want to give honor to some of those women. Some of those women you've seen on the screen behind me. as I put out the call and asked them to stand with me today, because I wasn't bringing you slides of data, research. You've already been talking about that all week. But I wanted you to go back with a picture. I said to my friends, I want to do something that no one else would do. I wanted to bring my community to the platform. I wanted to honor the women who couldn't get here today. I wanted to honor the woman who couldn't get child care to get here. I wanted to honor the woman that's in the conference hub watching this on a screen. I wanted to honor the women down in the global village who didn't have access to the main conference. I wanted to honor the grandmothers and the nanas and the women who are living and hiding behind the stigma and the reality still of HIV. I want to honor the women who, for whatever reason, have decided, I can't pull off this mask. I don't understand, Linda, when you tell me that there's no shackles holding you. I don't understand when you tell me that HIV was the last secret I could not keep. I do this very selfishly. The first time I spoke at a conference, I can remember, it was funny, Carolyn Burr is here in the room somewhere, I'm sure. They invited me because another speaker couldn't speak. I had never spoken at a national platform, and I'm not afraid to say I only came because they offered me $500 and my rent was due. It's real life. But something incredible happened that day. As I began to tell my story, as I began to tell my truth of being a whore, of using drugs, lying to my parents, stealing from my parents, stealing from society, I can hear clink, 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 the molestation, clink, clink, the rapes, clink, clink. There were shackles. Shackles was breaking loose from me. So I do this very selfishly because I don't want to feel those shackles on me any longer. I wanted to honor the sister who's fallen before us, Eva, Luis, Fern, Laverne. It's on their shoulders we stand today. If you would just give me one more minute, and maybe you have someone who's not in this room, but she's a soldier, and she deserves to be called to the platform. I'm gonna ask you if you would, just stand and call her name. Maybe she's Gina. Maybe she's Ronette. We speak your name. We speak your name not to be counted in surveillance and data and research. We speak your name for your boldness. We speak your name for making a choice to live. We speak your name for making a choice to fight. Nana, Vanessa, speak her name. Do you not have a woman?
Derek, Jennifer, Dolores, Kelly, Cinnamon,
Karen, Tanya. We speak their name because they are women. We speak their name because we cannot forget. We speak their name because they're worth fighting for. Ladies and gentlemen, please take the picture. Go back, make the change. We have already taken our mantle. Thank you. I dare not. I must do it. I wasn't going to do it, but I absolutely have to do it. Ladies and gentlemen, I want you to know I stand with our president. I'm waiting for change. It's one more election. It's get out the vote.
Please welcome Joseph Assombo, Country Director for the Elizabeth Placer Pediatric AIDS Foundation in Côte d'Ivoire.
Thank you. Good morning. Sometimes in life, there is that moment when it's possible to make a change for the better. This is one of those moments. This statement is not from me. This statement is from Elizabeth Glaser, 20 years ago, addressing the Democratic Convention in the US. It was true 20 years ago, but it's so real and so true today. I'm humbled and privileged to introduce our next speaker, Dr. Geeta Gupta, Deputy Executive Director of Programs at UNICEF. Prior to her appointment, she served as a senior fellow at the Bill and Melinda Gates Foundation, when she acted as a senior advisor to the Global Development Program on the strategic direction and management of a cross-cutting range of issues and projects. From 1996 to 2010, Dr. Rao Gupta was the president of the International Center for Research on Women, ICRW, where she conducted and oversaw research on topics ranging from the social and economic factors that affect women's use of maternal nutrition and healthcare services to girls and women's vulnerability to HIV. Under her leadership, the ICRW catalyzed policy and programmatic range change for women and children around the globe. Dr. Rao Gupta has led and participated in numerous global initiatives for women and children, including the UN Millennium Project Task Force on Education and Gender Equality, and she is the recipient of various awards, including the 2007 Washington Business Journal Women Who Mean Business Award. She earned a PhD in social psychology from Bangalore University and a Master of Philosophy and a Master of Art from the University of Delhi. Please join me to welcome Dr. Rao, who will tell us how close we are to turning the tide for women and girls.
Thank you very much. Good morning to all of you. That was a tough act to follow. Before I begin, let me thank my colleagues at UNICEF who helped me put this talk together, in particular Susan Cassidy, Amaya Gillespie, and Catherine Rogers and Craig McClure. Thank you very much. It's an honor to address this plenary session. I feel all the more privileged because I was here once before. In 2000, I addressed a plenary session of the 13th International AIDS Conference in Durban. It seems fitting, therefore, to reflect on the lessons of the past decade as we prepare to turn the tide on the epidemic for women and girls. In 2000, the world was struggling to find solutions to what had been, until then, a growing HIV and AIDS epidemic. It had left no region of the world untouched. But a closer look revealed that the epidemic was feeding on fault lines forged by deep-rooted inequalities and claiming its greatest toll on the most vulnerable groups: women, adolescent girls, men who have sex with men, sex workers, and injecting drug users, among many others. We have answered in large part the question that dogged policymakers, scientists, and activists alike during the early days of the epidemic. What will it take to halt and reverse HIV? The UN AIDS Investment Framework, shown here, responds to the question with 6 basic program activities: condoms, PMTCT, treatment, harm reduction for injecting drug users and targeted approaches for men who have sex with men and sex workers, male circumcision, and communication for behavior change. Several countries have now seen significant declines in new HIV infections due largely to the effectiveness of these basic program activities. We've also learned that the effectiveness of HIV prevention, treatment, and care is predicated on certain preconditions, chief among them gender inequality. In Durban, I explained that gender, the social construction of the biological difference between women and men, in very fundamental ways affects both women's and men's vulnerability to HIV. I also showed how economic and social inequality between women and men, with women typically having less access than men to education and social and productive resources such as income, land, and employment, results in women having less access to HIV information, prevention technologies, and healthcare services, and negatively affects their ability to protect themselves from risk. Over the past decade, policymakers have increasingly acknowledged gender as a determinant of the epidemic, as demonstrated by the gender-sensitive targets set at the UN high-level meeting on AIDS in 2006, and the emphasis on human rights and gender equality within the UN AIDS 2010 Global Strategy for Getting to Zero. The global recognition of the importance of gender triggered a proliferation of community-based projects and programs designed to reduce gender inequality and women's vulnerability. We have success stories. The Sonagachi program, which empowers Indian sex workers. The Image Project, which combined health, education, and microfinance initiatives to combat violence against women in South Africa. Program H, which introduced innovative strategies to reshape attitudes towards masculinity in Brazil, and many others. By challenging gender norms, both male and female, and calling attention to the importance of female empowerment to the AIDS prevention agenda, these programs broke new ground. But as we celebrate the successes of the past decade, we must recognize how much remains to be done. Despite substantial progress on various fronts, adolescent girls continue to bear the brunt of the epidemic. The statistics speak for themselves. Of the 4.8 million young people living with HIV worldwide at the end of 2011, 3 million were girls. In sub-Saharan Africa, the face of the HIV epidemic remains that of a young female between 15 and 24 years of age. The region's adolescent girls and young women aged 15 to 24 account for almost 70% of all young people living with HIV. In Eastern Europe and Central Asia, regions with the most rapidly growing HIV epidemics in the world, young people are at the epicenter of an epidemic fueled by unsafe injecting drug use. Of the 250,000 young people living with HIV in Eastern Europe and Central Asia, 44% are female. These adolescent girls and young women, our sisters and daughters, represent an unfinished agenda in the AIDS response and our greatest hope for turning the tide of the epidemic. I will focus the remainder of my talk on what it will take to reach and support them, to unleash their potential. In the first part of my talk, I will outline briefly why we must focus on adolescent girls before reviewing what we have done to reduce their vulnerability to the epidemic. I will conclude by recommending how we can do this through a set of actions that will, I believe, reduce the trajectory of new infections among adolescent girls. I'm acutely aware that the epidemic imposes multiple challenges on adolescent girls, who represent 60% of the 2.2 million adolescents living with HIV. These adolescent girls often serve as caretakers for their own children, siblings, and the elderly. Many girls have lived with HIV since childhood and now struggle to cope with their own sexual and reproductive development as HIV-positive adolescents. And other adolescent girls, while still in the prime of life, must cope with the onerous challenges of managing treatment as a daily routine. Without wanting to overlook the profound significance of any one of these significant challenges, in the interest of brevity, I will focus the rest of my remarks on the prevention of sexual transmission of HIV among girls, referring to treatment and care as they relate to prevention. Let me begin by considering briefly why adolescence matters to girls and women. Adolescence, the period from age 10 to age 19, is critical to the development of girls as well as boys. It is a period of growth and maturation, a phase when attitudes and behaviors are shaped and set, a time when independence and adventure are essential for growth, yet the possibilities for irreversible damage abound. The challenges that girls encounter in adolescence are particularly complex. A review of national household survey data published by UNICEF on the experience of childhood across the life cycle showed that while the differences between boys and girls are relatively modest early in life, they increase exponentially in adolescence. As this bar chart shows, more girls than boys are sexually active by the age of 15, if you look at the bars on the right. 11% of girls and 5% of boys are sexually active by the age of 15. The rapid succession of biological and social changes that girls experience in early adolescence creates what has been described as a density of transitions that renders girls susceptible to a vast range of risks. UNICEF's most recent Progress for Children report reveals that more than 1/3 of girls in the developing world are married before the age of 18, as shown on the last line of this slide. And in least developed countries, early marriage is the reality for nearly half of all girls in this age group, as shown in the second to last line. Adolescent girls who marry older, more sexually experienced men face an increased risk of HIV and other sexually transmitted infections. Another unfortunate but sadly predictable consequence of early marriage is early pregnancy. The most recent demographic and health survey data show that 1 out of 5 young women aged 20 to 24 had given birth to a child by the age of 18. In fact, many who see the UNICEF logo see not a child and a woman, but 2 children, one of whom happens to be the mother. While still in childhood, adolescent brides and mothers assume physically and emotionally demanding domestic responsibilities that often include caring for children, the ill, and the elderly. Responsibilities that are all the more strenuous when they include caring for family members debilitated by AIDS. And every day, we hear accounts of child brides struggling with isolation, humiliation, and a sense of abandonment as they try to come to terms with the reality of their lives as young wives, a reality that increases their risk of violence. In 2002, WHO estimated that 150 million girls under the age of 18 experience forced sexual intercourse or other forms of sexual violence. A national study in Tanzania reported that 3 out of every 10 girls aged 13 to 24 experience sexual violence. Strikingly, almost 1/4 of the girls said that the incident occurred while traveling to or from school. And 15% of girls said that at least one incident had occurred at school. In fact, the threat of sexual violence is one of several reasons why girls drop out of secondary school, especially if parents believe that remaining home is safer than being in the classroom. And yet we know that compared to their peers who are in school, adolescent girls who drop out of school face an even higher risk of early pregnancy, having more sexual partners, many of whom are significantly older, and are more likely to engage in high-risk behaviors that increase their risk of HIV infection. These gross violations of girls' rights are all the more troubling because of the heavy emotional and physical toll they exact. Sexual assault presents a direct risk of HIV infection from the assailant and sustains the risk over the longer term through the emotional and behavioral effects that include lower self-esteem, frequent partner turnover, and an increased likelihood to engage in transactional sex. High-risk sexual behavior, including transactional sex, is exacerbated by economic inequality between males and females. When girls depend on men for food, material goods, economic security, or protection, they are less able to demand safer sex, fearing violence or abandonment. Some girls forge relationships with older men with greater resources, partners who are more likely to have a higher number of prior sexual partners, thus increasing the girl's dependency and her risk. Many girls enter into such relationships with the belief that the material benefits will outweigh the costs, a fatally flawed calculation of risk. The evidence shows unequivocally the close association of asymmetries of age and income in non-marital relationships with increased risk of HIV infection. The risk for girls is exacerbated by their lack of access to information about safer sex, condoms, and other commodities to reduce the risk of HIV infection. Let's take the example of sub-Saharan Africa, where young women account for almost 70% of all young people living with HIV. Data from national household surveys show that in this region, just under half of young men who had sex with multiple partners in a calendar year used a condom in their last sexual encounter, while among young women with multiple partners, less than a third used a condom in their last encounter. This lack of access is not news. Adolescents have told us this repeatedly over the years. But in our effort to protect adolescents, especially girls, from the stigma and risk associated with early sexual activity, we, the adults, restrict their access to information and commodities that are meant to protect them. Ironically, our reluctance to acknowledge adolescents as sexual beings reinforces the very factors responsible for early and unsafe sexual activity. In sum, the underlying factors that deter girls from accessing and utilizing prevention strategies and increase their vulnerability to HIV include lack of access to information and commodities due to preconceived notions about adolescent sexual activity, social norms that support child marriage, condone violence against girls and women, and cast girls in subservient roles in society, and economic barriers to girls' education, and a false sense of security or empowerment that motivates adolescent girls to exchange sex for goods or favors. These are just symptoms of the double jeopardy that adolescent girls experience. They live at that perilous intersection of two key sources of inequality in society: age and gender. They are young and thus wield less power than adults. They are female, which gives them less control than males over their own destinies. As a result, for many girls, adolescence, which should be a time filled with promise, is in fact a time filled with peril. As a global community, equipping adolescent girls with the tools and the strategies to reduce their risk of HIV is both a moral obligation and a pragmatic strategy to achieve an AIDS-free generation. A business-as-usual approach won't achieve the results we need. The results from an ongoing modeling exercise by UNICEF and the Futures Institute shows what would happen if we continue along the current path. New infections will continue to rise among adolescent girls and boys. The top solid line represents girls and the bottom boys. The HIV investment framework sets out a bold proposal for enhancing the effectiveness and efficiency of the HIV response for all. It recommends coordinated action on 3 fronts. First, build the response around a set of core high-impact program activities. Second, deliver these activities in conjunction with strategies to address the legal, policy, and social factors to enable access to high-impact interventions. And third, anchor the HIV response within interventions in the areas of education, health, social protection, and economic empowerment to capitalize on development synergies. What could we achieve if we applied this approach to our work on adolescents? The modeling work I mentioned a moment ago shows that if we combine the high-impact program activities outlined in the HIV investment framework with strategies that enable girls to access those interventions and investments in girls' overall development, we can reduce the number of HIV infections in adolescents by more than 50% by 2015 and sustain the decline until 2030. A systematic review by the Interagency Task Team on Young People and HIV and the London School of Hygiene and Tropical Medicine confirmed the effectiveness of this approach for young people. They concluded that sexually active adolescents stand a greater chance of making healthy choices when they can obtain HIV prevention commodities and reproductive health services through youth-friendly health centers and access comprehensive quality information about sexuality and sexual health provided by adults or older youth with the requisite training. Young people need trusted adults that they can count on. Prevention information provided through mass media campaigns can also be effective. If we can combine that access to information and services with strategies that create an enabling environment, policies and laws that support the rights of adolescents, and broader investments in development, we will have created the foundation for a healthy transition into adulthood. So we have the evidence of what needs to be done. All that remains now is to translate our knowledge into actions that reach the many adolescents who need support, information, and services. What are the critical next steps that need to be put in place for that to happen? I have 5 recommendations. First, I call upon governments and their partners to develop context-appropriate, adequately resourced national plans that direct the high-impact program activities outlined in the investment framework towards the most vulnerable group of adolescents, with a special focus on girls, the young brides who get lost among the adults, and the girls who drop out of school. This may sound obvious, but recent evidence shows that this still isn't happening. Few country plans specifically target the most at-risk adolescents. And a 2010 analysis of prevention programs in 20 high-burden countries showed that investments in young people aged 10 to 24 represented less than 5% of all prevention spending in each country. Moreover, the investments focus primarily on the skill sets of in-school youth, even though the majority of adolescents and youth are not in school. Of course, action plans alone lead nowhere without ambitious leadership and dedicated commitment. We need the kind of leadership that challenges the idea that the risks faced by girls and women are somehow inevitable. The type of leadership that accepts the political cost of recognizing adolescents as sexual beings and that provides sexually active adolescent girls with the sexual and reproductive health services they so need. We finally have that kind of commitment for the elimination of mother-to-child transmission. If we demonstrate that same level of commitment for adolescent girls, we will drastically reduce infections in adolescence. We will strengthen the likelihood, of reaching the global EMTCT goal, and in so doing, we will transform the epidemic. Second, we need to work with other sectors. For adolescent girls, the education sector is a much-needed partner. While not a silver bullet for the many challenges that girls face, the education sector plays a major role in keeping adolescent girls in classrooms, ridding schools of violence, and providing students, girls and boys, with a sexual health curriculum that boosts their knowledge and reinforces their own agency by instilling in them the confidence to act on the knowledge they acquire. Those two components, resources and agency, are what empower girls to make healthy choices. And as we all know, empowered girls and women lead to empowered families, communities, and entire nations. Third, let us start early with younger adolescent girls, the 10 to 14-year-olds. By focusing on younger age groups, we can reach adolescents before they're sexually active, before their attitudes and behaviors are set. To engage the youngest and most vulnerable adolescents, we must first identify them and understand their needs. Adolescents between 10 to 19 are largely absent from national, regional, and global data sets, while adolescents 10 to 14 are almost invisible. Health statistics often follow girls through their last immunization at age 5. The girls then don't reappear in the data until they suffer an adverse event in adolescence, such as HIV infection or early pregnancy, at which point they're counted within the adult data set, even though they are still children. This situation is entirely unacceptable, all the more so because we know the devastating cost of data gaps. the health and well-being of adolescent girls. Fourth, we must invest in creativity and innovation to reach the hardest to reach adolescent girls. We can strengthen the returns on our investments in prevention by harnessing communication channels that have captured the imagination of adolescents the world over. Mobile technology, social media, and other new forms of communication offer enormous potential to reduce the risk of social isolation by connecting adolescent girls and adults in a virtual community of support. Programs like Soul City and the multimedia initiative Sugar, Love, Sex, Money, launched by PEPFAR, MTV, and UNICEF, are linking mass media and social media to the delivery of services such as HIV testing and counseling for adolescents. But innovation is not confined to the realms of information and communication technology. Cash transfers, conditional and unconditional, are a programmatic innovation pioneered in a range of country contexts to keep girls in school, increase the age of marriage, and reduce the risk of HIV. There are many other such similar innovative programs as shown on this slide. We need to encourage more of these kinds of innovative policies and programs. Perhaps a Grand Challenge Awards would be, is needed for social innovations to reach adolescent girls with information and services. Fifth, we must engage adolescent girls and boys as partners, leveraging their potential and making them a visible part of the solution. Adolescent girls are innovators and active agents of change, often out of necessity. Their seemingly boundless energy and creativity are fueled by an insatiable curiosity and a keen desire to make a mark on society. These characteristics make adolescents refreshingly receptive to new ideas and behaviors that can be harnessed for social change. Yet, adolescent girls are often the last to be consulted on social issues that affect them. As activists and community workers, we need to remind ourselves that adolescent girls are experts in their own reality and represent a vast repository of untapped potential. We must facilitate their transition into adulthood by equipping them with the knowledge to make healthy decisions and the self-confidence to act on those decisions. At UNICEF, we believe that our investments in elimination of mother-to-child transmission go a long way towards fulfilling our promise to protect children from HIV. But as our executive director said, we invest so much in keeping children alive in the first decade of life. We must not lose them in the second. Just a month ago, representatives of governments from around the world committed to a call to action to end preventable child deaths. Governments, together with UNICEF and a range of partners, are now translating that call into action under a banner of A Promise Renewed. Let us use this moment to do the same for adolescent girls, translate our promises to them into action. Over the last 3 days, I have been inspired by the many young women and adolescent girls, both HIV positive and negative, who have spoken eloquently and emphatically about the need for closer engagement and faster action. I hope you're here in the room this morning. Because to you I say, it is time for you to take the mantle. Don't wait any longer. Use your energy, your voice, and the power of your networks to hold us, the donors, the multilateral organizations, the financial institutions, your governments, we adults, accountable. An AIDS-free generation is within our reach today. As an adolescent growing up in India, you could say that I was part of an AIDS-free generation because I grew up before the world knew AIDS. It was an AIDS-free world, but a world in which women and the poor experienced immeasurable indignities, inequalities, and injustice. That is not the kind of AIDS-free world that we dream of today. We got this far because we knew that all along. We fought together for the principles of equity, justice, and inclusiveness. We must not lose sight of those guiding principles now. As we travel this last mile together, the world that we should be calling for is one that is not only AIDS-free, but is just. Because we will not be content. Because we will not be content to have the one without the other. We must be unrelenting in our commitment to create that kind of world. That must be our legacy, without any caveats, ifs, or buts. Thank you very much.